Blessed evening to one and all. I welcome everyone to the third Cardio-Obstetric Masterclasses with yet another important topic for discussion today, a case of Peripartum Cardiomyopathy. I now request our course director, Dr. G. Justin Paul, to give us to share a few words on the Cardio-Obstetric Masterclasses and today's session.
Good evening, all of you. My sincere thanks to each and every one of you who have logged in to this third Cardio-Obstetric Masterclass. This Cardio-Obstetric Masterclass was started with an intention of bringing together cardiologists, obstetricians, and obstetric anesthetists who are jointly involved in care of pregnant women with heart disease. So these are the women who need a greater care now and a greater coordinated care. With that need, in most of the underdeveloped nations and developing nations, there is a big need for cardio-obstetrics to develop as a prominent and well-recognized subspecialty. So in India as well, we would like to have this ongoing, and many individual cities and centers, they have it, but however, it needs to be the norm of managing every woman with heart disease. So with this idea, we are having this Cardio-Obstetric Masterclass every first Friday. And this third installment, we are discussing a case of Peripartum Cardiomyopathy, the commonest cause of heart failure around pregnancy. In each of these sessions, we will be having either a case discussion or a lecture or a case-based or a journal presentation. And it will be always moderated by representations from obstetrics, cardiology, and obstetric anesthesia, so that all aspects of management are covered. Today as well, we have this Peripartum Cardiomyopathy, which is a case is being presented from Iraq, and we have expert panelists. I request Dr. Anne Princy, our academic coordinator, to introduce the speaker and the audience and the panelists.
Thanks a lot, sir. So I'm happy to introduce the panelists for today's session. Dr. Chhabi Satapathy, Professor and Head of the Department of Cardiology, Maharaja Krishna Chandra Gajapati Medical College and Hospital, Berhampur, Odisha. She is an active member of the Vinkar Association. She has done pioneering work in women's health. She is the principal and co-principal investigator in more than 20 studies and has a number of publications in index journals. Dr. Manika Agrawal, Professor and Unit Head, Obstetrics and Gynecology, NEIGRIHMS, Shillong. She has written many papers published in national and international journals. She has been a guide and co-guide for many students, co-authored many papers which have received prestigious prizes at the national and international fora. She has undertaken many IEC-approved extramural funded projects. Dr. Kajal Jain, Professor, Department of Anesthesia and Intensive Care, PGI Chandigarh. She is the President of the Association of Obstetric Anesthesiologists, India. She is the Secretary of the ISA Chandigarh, Executive Member of AORA India, Indian College of Anesthetics, Anesthesiologists, ISSP. She is a member of the editorial board of JOACP, Sharjah, etc. And she's invited faculty at the National Fora as speaker, workshop coordinator, and scientific chairperson, credited with publications in national and international peer-reviewed journals and book chapters. I now would like to introduce the presenters of the day. Dr. Israa Fadhil Yaseen, Cardiology Clinical Pharmacology Specialist, Baghdad Heart Center, Baghdad Training Hospital, Medicity. She's the co-founder of the Iraqi Cardio-Oncology Program, a member of the Heart Team in the Cardio-Oncology Clinic, Medicity, Heart Team in Baghdad Heart Center, Cardiac Care Unit, and the Cardio-Maternal Unit in Baghdad Teaching Hospital, Medicity. She was the recipient of the Paul Dudley White International Scholars Award for the highest abstract from Iraq during the session AHA Scientific Session 2021. Over the past 10 years, she has conducted a number of trainings and workshops, and she has more than 50 publications and has authored chapters in books. Dr. Professor Hasan Ali Farhan, Professor at the College of Medicine, University of Baghdad, the head of the Cardio-Maternal Unit at Baghdad Heart Center. He's the president of the Scientific Council of Cardiology, founder and chairman of Heart Failure and the Cardiac Device Fellowship and Scientific Committee, Iraq, head of the Higher Committee of National Protocols, founder of the head of the Heart Failure Clinic, past president of Iraqi Cardiothoracic Surgery, co-chairman of the Arabic Board of Cardiology, consultant interventional cardiologist, Baghdad Heart Center, Medicity. He has more than 4 international awards, including the best reviewer of the Annals of Internal Medicine. He has peer-reviewed and contributed to many books and journals. He is an investigator in 10 ongoing trials and with more than 90 publications. So I welcome one and all. And before I would hand over the session to the moderator and the speaker, I request the audience to post your questions, and we'll be looking forward to answer your queries during the panel discussion. We'll also be having a live Q&A after the session and the lecture. So now I welcome the moderator for today's session, Dr. Justin Paul, sir, to lead us into the session.
So thank you, Dr. Annie, for introducing the expert team of panelists and the speakers. The speakers have done a lot of original work in peripartum cardiomyopathy. Particularly, they have been involved in generation of a risk score about which I will be listening to. And I'm sure in the audience, we also have equally elegant experts in this field. So if you have any comments to offer, kindly share it in the chat box. We will not be, since we are not able to have all of you same time in the panel board, we would like to have your comments and inputs in the chat box also. So in the chat box, as Dr. Annie said, we are not only looking for questions, but also we are looking for expert comments. So now I request Professor Hasan and Israa team to start your presentation of your case, and we'll have in between discussions from and getting comments from the experts. Please go ahead with your presentation.
Thank you so much.
Thank you, Justin. Thank you, Justin. Hi, everyone. It's given me a pleasure with my mentee, Dr. Israa. We will present this case and being among all of you for this very well-organized scientific activity. I will kindly request Dr. Israa to start the presentation case scenario for peripartum cardiomyopathy. Please, Israa, the floor is yours.
Thank you so much, and good evening for everyone. Today we will present a patient presented to our cardio-obstetric clinic at Baghdad Heart Center and Medical City in 2015. She was a 22-year-old lady, obstetric history, para 1, abortion 0. She delivered before 2 months, a healthy boy weighing 3.5 kg by elective cesarean section, and he was on breastfeeding. The BMI of the patient was 49.3. So she has morbid obesity with no comorbid disease. At presentation, her blood pressure 120/70, heart rate 110. NEHA class was 3. She was dyspneic with elevated JVP, peripheral edema, and pulmonary rales. Echocardiography was done for her, showed LV ejection fraction 42%, global hypokinesia with normal RV function.
So thank you, Dr. Israa. Dr. Manika, and as you can see that this is a patient who was delivered. You are an obstetrician, expert obstetrician in this field. Now, after delivery, for any complaints, the patients routinely, they come to the obstetricians. So now let us assume that this patient comes to you. So what are your comments, or what are your inputs, and how are you going to handle these patients? Would you like to give your expert comments here?
Yeah, sure. Since the presenting complaint is dyspnea and she has tachycardia, pulmonary edema, I will do a obstetric examination and ask her if there is any abnormal bleeding, PV, anything in relation to those complaints. I can do a per speculum and PV examination to see whether the uterus is involuting properly. So if there is no obstetric intervention required in this patient, as she's already a delivered patient 2 months back through a cesarean section and is doing well from obstetrical point of view, I think so I would like to refer this patient to a cardiologist for evaluation of her complaints, which may be related to her heart.
How often you see such patients in your practice?
Most of our patients, peripartum cardiomyopathy is not very common in this part of the land. But other heart disease during pregnancy, diagnosed or undiagnosed, we see around 2 to 3 in a month.
Okay. Dr. Chhabi, Satapathy is a cardiologist from Berhampur, HOD of Cardiology. Dr. Chhabi, if the patient is referred to you by Dr. Manika, and you come into the picture now, so what are the possible differential diagnoses that you will have in your mind, and how are you going to approach this patient?
Okay. Good evening, everybody. Now, this patient is a primey and very young, and it is 2 months postpartum. She has presented with congestive heart failure 2 months following delivery. So many of the differential diagnoses are out. We have few left for her. For example, it could be a case of viral myocarditis. Till now, we do not know about the dimension. This LV definitely dysfunction, and it's like a global hypokinesia. But this patient do not have a prodrome of any illness or respiratory infection or cough and fever. So left with us, it could be a case of Takotsubo cardiomyopathy or could be a case of AMI. They can present with acute onset of shortness of breath, but usually those are accompanied by some chest pain, and echo do not show any typical RWMA or a feature of Takotsubo cardiomyopathy. So it could be left as a case of PPCM or peripartum cardiomyopathy.
So thank you, Dr. Chhabi. Now we are thinking in lines of peripartum cardiomyopathy. Of course, peripartum cardiomyopathy is a diagnosis of exclusion. Now, they have clearly mentioned that there is a jugular venous pressure elevation, there is a peripheral edema, and there are pulmonary RALs. And she is in NOHA class 3, she has tachycardia. So the clinical diagnosis of heart failure is very clear in the postpartum period. So we will have to investigate more and see what is likely to happen. Now, the patient also is morbid obese, and they also have a possibility of a DVT and pulmonary embolism. That is also something that we need to have in mind. And we have Dr. Sunita Allanki in the chat box. So given this input in our input to us, definitely it's a valid input. But however, we'll see what's happening in the investigations. Dr. Israa and Dr. Hasan, would you like to proceed with, let us know what have you done about this patient?
Thank you, Justin. I have just a few words about the differential diagnosis and how we approach this patient. Diagnosis of heart disease in pregnancy and immediately after delivery is one of challenging condition in the medicine due to overlap between the symptom of a pregnancy or immediately after delivery, dyspnea, leg edema, and easy fatigability, and the real heart disease. And as our colleague Chhabi lists the differential diagnosis of peripartum cardiomyopathy, in our case post-delivery, 2 months post-delivery, so we have to think about the important list. It's myocarditis. How we can differentiate it, we need to just send for troponin, serum troponin, high serum troponin, favor the diagnosis of myocarditis. And we are emphasizing for the importance of biomarker to use in daily practice to help for make list of differentiation and final diagnosis of such case. And maybe the patient post delivery, we need to send her for cardiac MRI to have special pattern of late gadolinium enhancement and interstitial edema characteristic of myocarditis. Other diagnoses have been listed by our colleague, and we have to put in mind, especially post-delivery, and when there is history of stressful delivery, we can think of Takotsubo syndrome, and then we have chest pain, ECG, and apical ballooning of the echo LV by echo Other pregnancy-associated myocardial infarction, as you did mention, patient obese, morbid obesity, one can put in mind pulmonary embolism. Amniotic fluid embolism is very important, and we have to look by echo, right ventricular dysfunction. This is very characteristic, and other maybe hypertensive heart disease during pregnancy and pregnancy. Preeclampsia have been excluded. This is just when the case is presented before delivery. Israa, please, the next case. So this is suspected, the definition, just a few words about the definition to be make agreement for all of us. Heart failure secondary to left ventricular systolic dysfunction with ejection fraction less than 45%. Occurred the onset of occurrence toward the end of pregnancy or in the month following delivery, just exactly our case, mostly in the month following delivery. No other identified cause of heart failure. So peripartum cardiomyopathy, a diagnosis by exclusion. When we suspected a case of peripartum cardiomyopathy, we have to look for this diagram, and this can give us very nicely how to differentiate between the work up. Suspected acute peripartum cardiomyopathy, we have to send our patient natural urethric peptide on ECG, chest X-ray, and echocardiography. And we have to look for the result of natural peptide as a biomarker. When the nitropeptide is exceeding or increase with with LV ejection fraction less than 45%, and the history with the exact onset of occurrence peri-delivery or post-delivery, acute peripartum cardiomyopathy is likely in such case. And we have to exclude other pre-existing heart disease, just as chemotherapy-induced cardiomyopathy, especially in young women with the childbearing age, may got CA cancer and got chemotherapy and may be presented with heart failure during pregnancy. Congenital or valvular heart disease, other possibility associated with LV dysfunction or HOCM with LV dysfunction. Another arm, when the nitropeptide it's also an increase, but the ejection fraction equal or more than 45%, consider other cardiac and extracardiac origin of symptoms, just like pulmonary embolism, amniotic fluid embolism, isolated RV dysfunction, hypertensive disorder of pregnancy. When the patient presented with the normal natural peptide and ejection fraction more than equal or more than 45%, the diagnosis of peripartum cardiomyopathy is unlikely, and we have to consider extracardiac origin of symptom, anemia, pneumonia, renal disease, hypertensive disorder of pregnancy, and so on. Please, Israa, we can proceed for the next slide, complete the scenario. Yes, please.
Turn back to our patient. Initially, she was treated with intravenous loop diuretic. Then she was kept on beta blocker and ACE inhibitor, which was carvedilol tablet 12.5 milligram twice daily and ramipril tablet 2.5 milligram once daily.
So now what we have understood the story so far is that they have made a diagnosis of peripartum cardiomyopathy in this patient. Now, there are a couple of questions in the chat box. Could this be pulmonary arterial hypertension? Could this be pulmonary embolism? This patient's echocardiography did mention that normal RV function. So it is very important in every echocardiography, particularly in obstetric echocardiography as well, to mention about right ventricular function. Right ventricular function may be affected in about 25% of the patients with peripartum cardiomyopathy, and these patients have a very adverse long-term outcome. It's very important to ensure that this right ventricular function is normal and the size is normal. In a patient with acute pulmonary embolism, who have a lot of symptoms like this patient is presenting acutely, if they have acute pulmonary embolism, they will definitely have lung sign. They will not have lung signs. They will have a a dilated right atrium, dilated right ventricle, and pulmonary hypertension, or some amount of tricuspid digitation. Nothing is there in this patient. So hence the diagnosis of pulmonary embolism and related symptoms is not considered. They have rightly considered the diagnosis of peripartum cardiomyopathy in the presence of every systolic dysfunction. Now, we have started management. Israa, can you go back to the previous slide?
Yeah.
As you can see that, they have treated this patient with carvedilol and ramipril 2 months after that, and intravenous loop diuretic. Now, Dr. Chhabi, if this patient comes to you in 2024, now it is 9 years after that patient was managed in 2015. How differently you will manage this patient? Can you throw some light on that?
Sir, yes, in 2024, in this patient particularly, I want to re-emphasize why I never told about pulmonary embolism or amniotic fluid embolism, because already the echo report is with us. Otherwise, definitely that would have come a differential diagnosis in the postpartum period. But this patient had symptoms about 2 months and RARV are totally normal. So these two are excluded for this patient. Now, coming to the treatment in 2024, this patient is overtly in congestive heart failure with systemic congestion. So diuretic has been rightly given. But I feel when we are starting beta blocker for the patient, probably we have slowly up titrated and reached to 12.5 milligram BD. But regarding the ACE inhibitor, I have a doubt. This patient of peripartum cardiomyopathy in the postpartum period, the ACE inhibitor which are recommended are only captopril or it is enalapril. So whether we can give bisoprolol, other ACE inhibitors like ramipril or whatever, I don't know till now. Maybe Professor Hasan will send some message for us. And we could have also given some MRA to this patient because that's also recommended in patients of PPC.
Dr. Manika, I'd like to ask this question to you. This patient came to us 2 months after the delivery. Supposing this patient comes to in the 9th month, how are you going to handle this patient? What are your thoughts about that?
If this patient would have come to us in the 9th month with similar complaints, NYHA class 3, we would have immediately admitted her and probably sent for an opinion of a cardiologist to evaluate for underlying heart disease and to start treatment for the same. As an obstetrician, I would like to take care of the fetus, so we would start fetal monitoring, probably fetal heart rate monitoring twice a day, and biophysical profile to know fetal well-being once or twice a week. Now she's in the 9th month, so we have to now also think about the mode and the time of delivery. From obstetric point of view, we can wait till 40 weeks of pregnancy for the onset of spontaneous vaginal delivery. However, sometimes the cardiologist wants an early delivery for maternal well-being. In that case, we would like to plan the patient for a short induction in case the cardiologist tells us that she can withstand the stress of vaginal delivery, or if she cannot withstand the stress of normal vaginal delivery, we would also consider elective cesarean section in such a patient.
Thank you, Dr. Manika. Dr. Kajal. Dr. Kajal is an obstetric anesthetist of a very leading obstetric anesthetic center. She's heading the department. So my question to you is, as an anesthetist, when do you think you should be involved in managing a patient with a high-risk heart disease? By and large, we find that when the patient is on the labor table, you please call the anesthetist. That is how the practice goes. What is your opinion on that? When do you think you should be in the picture?
Thank you for asking that question, because that's a very important question. And these days we are talking about an pregnant heart team. And in this, we figure out as important components, like we are also one of the team members. And I feel as early as you can show us the patient. If she comes to you, see, it's a disease of the end of the spectrum. So the minute you diagnose these patients with peripartum cardiomyopathy, I think the anesthetist should be also kept in the loop, because they also want to know how hemodynamically the patient is stable, what are the drugs she's on, and whether she's on anticoagulants, so that they can plan and then they can counsel the woman for early neuraxial analgesia, which is the current recommendation now by the obstetrics societies, as well as the guidelines from the cardiology, that these patients should not be undergoing any stress and anxiety which can precipitate their cardiac failure. So I think we should be involved as early as possible.
So thank you. Thank you, Dr. Kajal. So what I gather is that if the patient comes in the 9th month, and if they're able, they stabilize well and the patient's heart failure is controlled, she can be improved to a class 2 status and she is able to lie down comfortably with adequate labor analgesia, maybe a trial of vaginal delivery can be given. But how if the patient continues to remain unstable, what is recommended is a cesarean section. Now, we have given carvedilol, ramipril, and loop diuretics to these patients. There are also thoughts about bromocriptine in these patients. We have a poll on bromocriptine because many times whenever we talk about Shruti, can you launch the poll on bromocriptine? I request the audience to answer the poll. We'll discuss that after you answer. We'll give 30 seconds to you. I request all of you, you'll be seeing a poll in front of you. Are you able to see that? Yeah, please participate. Please vote. Make your choices. Fine. I think more than 60% have voted. That is good. Maybe another. Yeah, you can stop the poll now, Shruti, but let the results remain. Okay, so most of you have given severe peripartum cardiomyopathy postnatal, followed by severe peripartum cardiomyopathy anytime. Now, anytime would include antenatal. Bromocriptine is not recommended in the antenatal patients. So we always can give peripartum bromocriptine in the postnatal patient. And again, I think Dr. Hasan will have a slide on that. So I'll leave that to him when he discusses that. Probably he can come to that also. Now, other thought process are, now bromocriptine, when in severe peripartum cardiomyopathy, should we stop lactation is some of the thoughts that has been discussed. But from the IPAC registry, Dr. Dennis McNamara and team have shown that whether you stop lactation or you continue lactation, there was no difference in the actual outcome of these patients. So lactation can be continued. However, in very severe peripartum cardiomyopathy, when we are stopping lactation, I will rather prefer to, though there is no sufficient data, we have very potent heart failure drugs now, sacubitril valsartan and sodium glucose co-transport inhibitors. These have not been given in any large-scale studies in peripartum cardiomyopathy, but postnatally in patients in whom lactation is suppressed, they have been given in isolated case reports are there. So probably I personally will be comfortable to give SGLT2 inhibitors and ARNI in a patient with peripartum cardiomyopathy whose lactation is stopped. But however, this is an individual opinion. I'm sure more data will be coming in the pipeline. But what is important is when patients are given optimal medical management with beta blockers, the outcome is good than when the less than optimal medications are given. So now I request Dr. Hasan to take the discussion forward and tell us I think there was one question about anticoagulation also. Do we have an anticoagulation poll, Shruti? Can we do that also? Is there an anticoagulation poll, Shruti? Yeah, please. So that Professor can discuss these. I request all of you to vote for this also. The question is written none of the above. So, which of the following is not an indication? Okay. Now we can stop the poll. And I request Dr. Hasan to take the discussion forward.
Okay, thank you. Israa, you can do it, so?
Yeah.
Yes, please.
Regarding the use of anticoagulant in peripartum cardiomyopathy, in the updated 2022 American Guideline for the Management of Heart Failure, it was mentioned it's a class 2B to use anticoagulant in case of LV ejection fraction less than 30 at the time of diagnosis until 6 to 8 weeks postpartum, although there is a debate about efficacy and safety. Therefore, honestly, we don't prescribe anticoagulant because it's low recommendation and uncertainty of safety and efficacy, except during hospitalization, because all patients with LV dysfunction, we have to keep on anticoagulant during hospitalization, or in case of the patient on a bromocriptine.
Israa, just can you hold on a moment? Can you share the results of the poll, Shruti? The results of the anticoagulation poll. We'll just share any comment on that.
Sure.
Yes.
So that the audience will be benefited. As you can see, that the right answer is none of the above. Say, for example,
Yes.
in embolism, there is definitely a need for anticoagulation. Patients with peripartum cardiomyopathy can have ventricular intracardiac thrombus. So if there is a thrombus in the ventricle, they will need anticoagulation. If there is a systemic embolism, there is a need for anticoagulation. If there is an atrial fibrillation, there is a need for anticoagulation. And whenever bromocriptine is used, now peripartum period is a procoagulant period. Bromocriptine is also a procoagulant drug. So whenever bromocriptine is used, even though the recommendation is not very strong, it is generally advised to do either therapeutic or at least prophylactic anticoagulation therapy. And Israa just mentioned about the low ejection fraction, LVF less than 35. The strength of evidence is very low, but can be given. It is definitely not a contraindication. Can be given in very sick patients, but then the indication is very low. So the right answer will be none of the above for this one. Yeah, you can please go ahead, Professor.
Yeah. Regarding the use of bromocriptine in peripartum cardiomyopathy, in 2018 ESC guideline, European guideline, it gave the recommendation class 2B to use bromocriptine in patients with peripartum cardiomyopathy to stop lactation and enhance recovery of LV function. And we should, as you said, use a prophylactic or therapeutic anticoagulant concomitant with bromocriptine. Prof. Hasan?
Yes.
Could you continue, please?
Thank you, Israa. Yes. So, continue to our scenario. During patient education discussion, she asked when her LV function returned to normal state. This is one of the most frequent questions have been asked by the patient when we sit together and discussion about patient education. And recently, we have published a very nice articles in team of ESC Euro Observer research program, Peripartum Cardiomyopathy Registry. This is wide world registry, more than 160 centers worldwide, and I think initial enrolled patients, more than 700 patients worldwide. And this article just well-designed novel score for predict left ventricular recovery in peripartum cardiomyopathy delivered from the ESC Euro Observer Research Program, Peripartum Cardiomyopathy Registry. And this score have been include the next slide, include the 6 variable, which left ventricular ejection function, initial LV ejection fraction, and scored 1 point. And the LVN diastolic diameter, when the diameter is less than 53 millimeters for 4 points, while from 53 to 61 millimeter for diastolic diameter of LV scored 1 point. And the third variable of the score is high human development index, and we will discuss for the next slide about the human development index that's considered and included in this score. The fourth point, duration of symptom, less than 10 days from duration of the symptom, 1 point. And the other variable is the QRS duration. When the QRS duration less than or equal to 80 milliseconds, the patient scored 3 points. And when wide QRS from 81 to 109 milliseconds, the patient scored 2 points. And if there is any preeclampsia, the patient scored 1 point. This is the newly designed predicting LV recovery in peripartum cardiomyopathy. Next, please. Regarding the Human Development Index, we need to know this is from website, and for each country there is a Human Development Index, which includes the life expectancy at birth, expected years of school, mean years of school, and gross national income per capita. And for instance, this is for Iraq, the development index was 0.670, and this is not granted for any score for the patient. And this, the other slide show the score, human development score for India, and again it's 0.607, while the high human development index 0.700 to 0.799. This is just we need to how to calculate this score for our patient in order to predict the LV recovery for our patient. Israa, yes, please. For our patient, as we did mention, the LV ejection fraction was 42, and the patient got the score. And for LV-EDB, unfortunately, we didn't have the initial data for LV-EDB, so for that we dropped the score. And high index, below the 0.700, so no score. The symptom more than 10 days, and the QRS duration 80 millimeter, and preeclampsia no. For our patient, the total score 4, and the rate of predicted recovery 43. Keep in mind, we didn't include the LV and diastolic pressure because the unavailability of data. And I think this score can answer the patient, and they need more validation for sure. But we have to have an idea for ask our patient when they did ask when we come back to the normal state, or how much the chance for recovery. Yes, Israa?
Yeah.
Okay, please.
Thank you. At 6-month follow-up of our patient, NEHA class was 1, improved. In functional class, blood pressure 120/80, heart rate 80, and echocardiography show LV ejection fraction 57% with LVN diastolic dimension 57 millimeter. So there was improvement in LV function. At this point, patient asked to stop the treatment at 6 months. Prof. Hasan.
Prof,
I think please.
Let's take 1 or 2 points here. There was one good question there in the chat box, like which anticoagulation is advisable along with the bromocriptine once the patient is discharged? Or do you start Novax or warfarin? It's a great question, but as of now, we don't have a great answer for it. But the good news is that the rebirth study by again the in US is ongoing, where they're enrolling patients with peripartum cardiomyopathy and testing the efficiency of bromocriptine. in patients who are willing to stop lactation, they are giving bromocriptine. And in these patients, they are giving rivaroxaben as the preferred anticoagulant. So since we don't have specific data on this one, but particularly when the patient is not lactating, we can comfortably give rivaroxaben or warfarin. Doesn't really matter. Or some patients are given subcutaneous low molecular weight heparin. So these can be given for the patients.
Justin, I think and added to that, we can use low molecular weight heparin because the guidelines say prophylaxis. We have the prophylaxis for low molecular weight heparin, and in our daily practice, we used to use low molecular weight heparin for short time, 1 or 2 weeks. I think this is one of our practice from our side.
Yeah. So I think for those of us who have listened, it is particularly the cardiology team, the question that is going to be asked is, will this patient recover? When is it going to recover? I think most of us would have faced this question. The simple answer from Professor Hasan and team's score will be, if the patient has a non-dilated LV, the patient has a LV ejection fraction little more than 35%, and the patient has a narrow QRS, straight away they get 8 points, and there is a 80% chance of recovery. That's a great score. My request to those of you who are listening is that you can try validating the score in your own centers. If you can collect a group of 10, 20 patients and see whether the score works and how it is validated in the Indian setting, that may be very helpful and it will be definitely worth publishing. So I request all of you to venture into that. Professor Hasan, please go ahead with your...
Yes. Please do that. We need more validation for this score. And one of most frequently asked question about the treatment and for how long we have the treatment. This question always we face it and asked by our patient. From this slide, we have to we would like to clarify the chronic drug therapy in patients with peripartum cardiomyopathy. The drugs may be persisting heart failure and absence of complete LV recovery. Beta blocker essential for all patients in standard or maximized dose. AC inhibitor in case of postpartum delivery essential for all patients in standard and maximally tolerated dose. ARAP recommended in patients who do not tolerate AC inhibitor, and ARNI recommended in patients with LV ejection fraction less than 40% who are symptomatic despite the maximum dose of beta blocker, AC inhibitor, ARAPs, and MRI. The MRI recommended in patients with LV ejection fraction less than 40, preferably bilirubin due to less hormonal side effect and less blood pressure reduction compared to the spironolactone. And everybody recommended in patients in sinus rhythm with persistent heart rate more than 60 beats per minute at rest despite the maximum tolerated dose of beta blocker. And diuretics is recommended in patients with fluid overload. And about the complete and sustained recovery ejection fraction less than 55 and NEIGRIHMS class, NEIGRIHMS function class 1. This is the definition of complete recovery of patients with peripartum cardiomyopathy. Keep in mind, ejection fraction should be more than 55 and NEIGRIHMS class 1. Continue all drugs, beta blocker, AC inhibitor, ARAPs, ARNI, at least to 12 or 24 months after full recovery. 12 to 24 months after full recovery. Individual approach, discuss with the patient. This is very important. Patient-centered approach. Discontinue stepwise and monitor symptoms and LV function. Start to discontinue MRI first, and then AC inhibitor or ARAPs or ARNI, and then lastly the beta blocker. This is very important to deal with the management of guideline of peripartum heart failure. And we note that all the updated guideline recommended to treat patients with peripartum cardiomyopathy or heart failure in the pregnancy, just like the treatment of other LV dysfunction, especially after delivery. Yes, please. Israa, you have to continue. If Justin no have any idea, any comments, can we proceed?
So what is your opinion about subsequent pregnancy? Can this patient have a subsequent pregnancy? This was the question I think most women do ask.
Yes.
So, panelists, you would like to have any comments here, Dr. Manika, Dr. Chhabi?
I would send the patient to cardiologist for assessment of repeat risk of getting cardiomyopathy and how safe it would be for the patient to become pregnant again. I think so. The cardiologist should take a call on this and explain to the patient.
So what I feel, this patient is still on beta blocker and ACE inhibitor. She is not out of the drugs. And number two, I could find the LV end diastolic dimension is still higher beyond what it is normal. So this patient should gradually be withdrawn the drugs, whatever she is getting now in a phase-wise manner. After completion of withdrawing of all the drugs, we have to wait for 3 months to see that she has fully recovered with an ejection fraction of more than 50-55%. Then we can have a W-termin stress echo or whatever, like to see whether this patient can tolerate some form of stress. Then we can ask this patient to go for next or subsequent pregnancy.
I think Dr. Chhabi's point is very valid, and this is a stance that I will also like to take, because this aspect, however, it has not been tested in any of these studies, whether the stress-induced LV dysfunction, absence of stress-induced LV dysfunction, will it be able to give a better outcome in the long run? In this relevance, I think I'll just share 2 of my slides, which I had probably given in one of the talk elsewhere. I'll just share the slides. I don't know. Are you able to see the slides here?
Yes. Yes, sir.
Okay. Now, this is a study that was published very recently, a few months back. See, they had followed in Scotland over 10 years. 76% of these patients recovered. But the sad part of it is, of those who had recovered, 13% of them went on to have a decline in LV ejection fraction despite initial recovery in the absence of a subsequent pregnancy. So in the absence of a subsequent pregnancy, 13% of those who had recovered had a worse LV function, went back to LV dysfunction. This is one thing that I wanted to share. And the other thing that I wanted to share was, not this one. This is another study that I wanted to share with you. This again was published about 3 months back in JACC, I think. Here, what you find is they had one of the largest study of subsequent pregnancy followed up over a period of 8 years.
Right.
So 45 patients with 78 subsequent pregnancies, of which 57 had a recovered LV function and 21 had a non-recovered LV function. If you look at that, when they allowed to have a subsequent pregnancy, the relapse of a peripartum cardiomyopathy during subsequent pregnancy was 50% in those who were not fully recovered. But in 20% of those who had fully recovered, there was a recurrence or relapse of LV dysfunction during subsequent pregnancy. Now, coming to the death rate, in 5 years, mortality was 3% in patients who had a subsequent pregnancy with the normal recovery. And if you look at the comparison at 8 years follow-up, the longest term follow-up of subsequent pregnancy, if you look at the green lines, yellow lines, it looks reasonably good. Like, the relapse of peripartum cardiomyopathy was less, and persistent LV dysfunction after subsequent pregnancy was less in those patients who had a recovered LV function. But if you look at the cardiovascular mortality and all-cause mortality in these patients, they had about 3 to 6% all-cause mortality and 2 to 5% cardiovascular mortality, whether they had LV dysfunction, LV function recovery or not. So even in the absence or presence of good LV function recovery, these patients went on to have a bad outcome. So it is not a very clear statement that we can make that if your LV function is good, you will have a safe subsequent pregnancy. The data is yet to be clear. But till such time, probably, if the GNS is very good and the stress-induced echo is very good, probably that we can use as a criteria for allowing pregnancy. Now we'll get back to you, Professor Hasan. Sorry for taking this short detour.
Okay, thank you. I just did answer some question in the chat box. It's very nice and interesting question. Israa, can we have your follow-up slides?
Yeah, thank you so much. I agree with Dr. Justin that relapse or recurrence of peripartum cardiomyopathy with or without subsequent pregnancy. This may be agree with the new guideline of heart failure, the American guideline that advise a patient with heart failure in general regarding peripartum cardiomyopathy to continue anti-failure even after recovery of LV function because of possibility of recurrence. We always advised our patients and educate them that there is a possibility of recurrence. For this patient also, she was the first patient in our cohort, and actually Prof. Hasan Al-Farhan did W-tamine citrix echo for her, and it showed initially GLS and echocardiography showed normal LV function, but W-tamine citrix echo showed still impairment. Therefore, we kept her for additional 6 months on treatment and returned back to second W-tamine citrix echo, which with good results. So we advised her to continue to start planning for pregnancy. So for this patient, baseline ejection fraction was 42. At 6 months, improved 57. At 1 year, 59, then 2 years, 63, and at 3 years, 62, and at 4 years, the ejection fraction was 61. So there was an improvement in LV ejection fraction.
So thanks, Israa.
Thank you, Israa. What did you mention for that? I totally agreed with that discussion by our colleagues, and I just admit for this patient, I think, Israa, you know that this is the patient, and now she's pregnant for the second subsequent pregnancy, and we used to follow her, and she's in first trimester. And the subsequent pregnancy is still very, very challenging and difficult to answer this question. And we need teamwork, patient-centered discussion, and you have to mention for the patient, for our patient, that is still high chance for recurrence during pregnancy, and this is different from other type of heart failure during pregnancy or other type of heart failure. And I think, Israa, we discussed with our patient for risk stratification with patients with peripartum and residual LV dysfunction. This is class 4, and contraindication for pregnancy and for subsequent pregnancy, while peripartum with recovered LV dysfunction by the WHO modified risk stratification is still a class 3, not class 4. Please, Israa, if you add more.
Yeah, thank you so much. One of our patient also, she didn't get LV recovery, and she got unplanned pregnancy. When we advised her to make the abortion after a multidisciplinary team discussion, she refused, and she said that I can't tolerate the risk, even death, because it's a precious baby. So this is among the scenario that we see in the clinical practice, The patient was lucky, actually, and she completed the pregnancy uneventful despite residual LV impairments. So return back to our case. During subsequent pregnancy, NEHA class was 2. A patient complained from palpitation, reduced LV ejection fraction to 55, although it's normal, but it was 61, reduced to 55%, and increase in LV and diastolic dimension, 53. She continued bisoprolol administration during pregnancy. So the outcome of this pregnancy, the patient delivered at 37 weeks of gestation plus 1 day, uneventful by elective cesarean section due to history of cesarean section and patient's preference. She delivered healthy boy weighing 3.3 kg. If we see the ejection fraction after at 4 years follow-up, when she was 8 weeks pregnant, the ejection fraction was 66. At 32 weeks, reduced to 55%. And at 6 months post-cesarean section in 2020, LV ejection fraction improved to 57%. And she was kept on metoprolol, succinate, and lisinopril, and hydrochlorothiazide. Thank you. I think we finished the case scenario of
now I'd like to ask Dr. Manika and Dr. Kajal. Now, this patient now comes to us pregnant, the history of LV dysfunction and heart failure. So what will be your strategy for labor, Dr. Kajal, anesthetist?
Yes, as Dr. Hasan has already pointed out, that you have to risk stratify them during pregnancy, and he has said that according to the modified WHO classification, they fall in 3 or maybe 4 and not less than that. So first and foremost, I would like to tell the audience that whenever a patient is having such risk stratification, patient should be referred to a center where there is provision for a trained obstetric anesthesiologist 24/7. Even if we have thought about doing any anesthetic technique, which I'm going to talk about, we should not forget that these patients are liable to hemodynamic instability and challenges through their cesarean section and even beyond that. So first and foremost, we should understand that are we empowered to deliver this patient in a facility or no? Number 1. Number 2 is, like, if this patient came to us, then we again do a pre-anesthetic checkup. And along with that, we also look at NYHA status. So in this case, patient's NYHA status is okay. So if the patient's status is okay, like 2/3, because mostly these women are 2 by nature of their pregnancy. So if she's 2/3 and she's comfortable and she's able to tolerate the hemodynamic changes, which you can assess case to case, then we can go ahead with the placement of early neuraxial analgesia in the labor room itself. And that can cut down the stress of catecholamine surges and increase in heart rate and increase in blood pressure, which are poorly tolerated by these women. So if at all, we can do that. And if in this case, she was planned for elective cesarean section and the patient was not having NYHA more than 3, she was NYHA 2. So I would recommend that these days we are promoting the use of low-dose spinal anesthesia with the epidural catheter backup. So what we do is we inject a very small volume of drug into the intrathecal space, which does not cause big hemodynamic compromise, because we do not want any hemodynamic compromise. So we keep our pressures at the baseline, and we have to use some drugs like vasopressors to keep the pressures up. So with that small dose, we are able to cut down the drastic fall in blood pressure. And that is what we want. The afterloads and the preloads have to be determined in these cases. Heart rates have to be maintained. So that is what the anesthesia dictum says. And then keep the drugs ready to keep the pressures up. So the drugs of choice, if the heart rates are low because you're using beta blockers, so we'll like to avoid phenylephrine. We can use noradrenaline or ephedrine, either of the two. And if we are planning to do spinal, we should also be monitoring their invasive blood pressure. That is why I said they have to be delivered in a higher center, because they're at risk of deterioration anytime. And we should monitor our spinal the same way as we monitor our general anesthesia. We should put an IBP, and if the patient is hemodynamically unstable, she's having rails and she's showing signs of failure, then definitely one has to go in for general anesthesia and a backup for ICU. Whereas for patients who are undergoing under low-dose spinal anesthesia with NYHA 2 or 3, they can be seen in HDU post-operative.
Thank you, Dr. Kajal. Dr. Manika, I would like to add some points.
Yes.
Please.
From an obstetrician points of view, the patient has 3 high-risk factors. She's previous cesarean, she's morbidly obese, and she has a heart disease. So I would think that in this particular patient, doing a cesarean section electively would be the safest option. Because if we plan her for vaginal birth after cesarean section, we have to monitor for scar dehiscence. And for that, we have to look for scar tenderness, which may be difficult to elicit. So because she's also a previous cesarean and morbidly obese, plus a heart disease, I would opt for elective cesarean section as a safest option.
Thank you. Thank you. I think, I request all the audience to look at the chat box as well. In fact, Professor Hasan has answered a lot of questions in the chat box. Thank you, Professor Hasan. The remaining questions, I think 3 of them are remaining. Dr. Shiba Thakur, thanks for asking the question. Which could be the best biomarker for prediction of recovery in peripartum cardiomyopathy? I'm not too sure, very strong data is there, but there was a publication in, I think, JSCC a couple of years back, 2 years back probably, where they had tested a couple of biomarkers, including soluble FLT1 and I think placental growth factors. High levels of these factors, and including BNP also, are associated with the less likelihood of recovery. So if anything else, I think Dr. Shiba, I request you to kindly answer back in the chat box. That would be very helpful for the audience. And the other question is that, can you use inotropes in acute heart failure for peripartum cardiomyopathy? Of course, yes. And I think Dr. Kajal has also touched it upon. And yeah, Dr. Anita Saxena, madam, is there. I think Dr. Shiba has been our previous faculty, and Dr. Anita was our first. Anita Saxena, ma'am, was the first. We launched the program with her talk only. Thank you, madam, for always joining and supporting us. And Dr. Hasan has said that studies have shown patients with eclampsia has a high chance of LV recovery, and that is why a score of 1 is given in the ESC EORP score. So, any other live questions there? I think all have been done. So if that is done, then we'll go to, I think I request Dr. Anne Princy. Any comment? If I request her to go ahead with, I think Dr. Manika wants to make a comment. Please go ahead.
I just want to share a patient which I treated in January this year. The patient had delivered somewhere outside, and just half an hour after delivery, she complained of chest pain, severe chest pain. So she was sent, referred to our institution, which is a tertiary care institution. When I saw her, she was in the ICU. She had very low BP and was on 2 vasopressor agents. Echo was normal, but her cardiac biomarkers were increased. The cardiologist opined that it may be a case of sepsis. However, it was a case of postpartum collapse without any particular etiology. So we got a CT angio done for us. And in the CT angio, pulmonary embolism was there. Right. And after starting low molecular weight heparin, within 6 hours, patient made a dramatic improvement. So my recommendation was, in any patient of postpartum collapse, like this patient, within half an hour of delivery, which is the time for Licor-MNI embolism to occur. So in any patient of sudden postpartum collapse, I think so if CT angio facilities are available, we should get it done, because Licor-MNI embolism is also a diagnosis of exclusion. That's all that I wanted to share with everyone.
So thank you. And now with that, I request Dr. Anne Princy to go ahead with the take-home thoughts.
Thank you, the panelists and the presenters. Thank you, Hasan sir, for a wonderful presentation on peripartum cardiomyopathy. I would just like to highlight certain points that we can take home. So the first one is peripartum cardiomyopathy is a diagnosis of exclusion. So as Madam highlighted in the end, so it is a diagnosis of exclusion, but however, it requires a high degree of suspicion. And one more thing, it is an entity which is lately diagnosed because overlapping the symptoms of a normal pregnancy. Secondly, peripartum cardiomyopathy is the most common cause of heart failure during and shortly after pregnancy. Some of the important risk factors include gestational hypertension, obesity, multiple gestation, family history, substance abuse, and advanced maternal age. So as we saw, management of peripartum cardiomyopathy followed the board scheme. And coming to the bromocriptine therapy can be initiated in patients with severe heart failure to enhance LV recovery. And during bromocriptine therapy, we have to keep in mind that cessation of lactation should be discussed with the patient, and prophylactic or therapeutic anticoagulants is recommended. Now, some of the important indicators that show there is a poor outcome in peripartum cardiomyopathy includes a severe LV systolic dysfunction of EF less than 30, RV systolic dysfunction, as Sir has mentioned rightly, and an intracardiac thrombi, a LV end-diastolic diameter of greater than 60 mm, a low TDI, and preeclampsia. So now coming to wearable defibrillators for women with new onset PPCM and severe LV dysfunction, it can be used until recovery or until ICD is indicated for about 3 to 6 months. And coming to cardiac transplantations, in these patients, it is associated with a high rejection rates and lower survival. And coming to stopping of heart failure medications, once a patient starts recovering, it has to be done in a it should be weaned in a stepwise manner with frequent clinical and echocardiographic assessments. Now, with evidence of a deterioration of LV function, the medical therapy needs to be restarted. Similarly, a deterioration of the LVEF with gradual withdrawal of beta blockers as AC inhibitor treatment is a good indicator that full recovery has not yet occurred. Now, despite full recovery of resting LVEF, the residual risk of recurrent heart failure is associated with persistence of a subclinical systolic dysfunction that is shown by the GLS. Similarly, a pharmacological stress testing, that is a presence of inotropic contractile reserve, is a better predictor of LV functional recovery during follow-up. Now, coming to before pre-discharge, there should be a adequate clinical evaluation done and a multidisciplinary counseling has to be given. And to keep in mind, this is one of the entity which needs a very important, like it requires a cardio-obstetric care, and that should be kept in mind always. So now coming to breastfeeding, it is not associated with adverse outcome and persistent myocardial dysfunction, and progesterone releasing subcutaneous implants or Mirena IUDs can be used as a safest choice. Coming to the echocardiographic assessment, that should be done pre-discharge, 6 weeks, 6 months, and annually. Reassessment of LV function is advised even after drug discontinuation, followed by annual clinical as well as echocardiographic assessment. Now, during subsequent pregnancies, as we have discussed a lot, women with peripartum cardiomyopathy should be closely followed up with serial clinical assessments and ecocardiogram, along with the BNP level from before conception until delivery, which includes end of the first trimester, end of the second trimester, first month before, 1 month before delivery, after delivery, pre-discharge, and 1 month post-discharge. So finally, to have this in mind, pregnancy is a stress test for life. So even though peripartum cardiomyopathy patients recover their cardiac contraction, long-term follow-up is necessary. Thank you, one and all. Thank you for joining.
Thank you, Annie. Thank you for the take-home thoughts. You can stop sharing. So now it's time for Thanksgiving. Our sincere thanks to all the audience who really, joined the program and encouraged us. The very purpose of this meeting is to network with one another and to share knowledge with each other. As you can see that today we learned a lot from the audience. A lot of our audience have actually participated and generated the discussion. So we are really looking forward for you in each and every of our master classes, because we always feel audience are not just here to learn, but here to share their inputs. Many of your expert panelists, and we are also not here to share, we are also here to learn, because every time I attend a master class, I learn a lot from the expert panelists, the speakers, and from the audience. So my sincere thanks to you for all the audience. And for those of you, we are planning to have the master class every first Friday, and we'll be having the same predominant pattern. And We also have a group called Cardio-Obstetrics India. If you are not in the group, please let us know. We'll be definitely adding you to this group. And sincere thanks to each and every one of you. Now, my sincere thanks to Professor Hasan and Dr. Israa for your valuable contribution, value addition to this program. You have done a pioneering research work in generating a score. We know it is very difficult to organize and do research, and you both have done this in a wonderful way, partnering with the best in the field. You know, if you look at the paper, it is that Karen Sleva is there, Sorel Goland is there. In fact, you have partnered with, shared shoulders with all the big names across the world, and you yourself are a big name. So thank you so much, both of you, for your participation and your presence and your contribution. And nothing more made interesting, if not for our panelists, our expert panelists from all the three fields. Dr. Manika, Dr. Kajal, and Dr. Chhabi from the fields of obstetrics, anesthesia, and cardiology. My sincere thanks to each of you. You have been really contributing and made this discussion a very palatable way. In fact, not only it is important to give good points, but also in a way that is palatable, easily digestible, and you made it in such a wonderful way. Thank you so much. And thanks, Annie, for always being there and getting the program ready. My sincere request to those of you who are participating, please partner with us. We welcome you to be faculties. We are sharing the faculty link in the group. Those who would like to contribute, you please share. And please share these inputs to those others as well. There is somebody who has raised a hand now, and I think a lot of new points have been given. We'll continue answering these questions for some more time. Can cabergoline be used instead of bromocriptine for the cessation of lactation? Yes, it can be done. In fact, from the German cabergoline registry, there was some data about some 4 patients in whom they had used, and they have a protocol for use of cabergoline also. So we probably can share it in the cardio-obstetric groups if you're interested. And I think Dr. Shiba has shared some more points. Thank you, Dr. Shiba. Thank you so much. And any other points? Dr. Anil Kumar Mahapatra, I think he has raised his hands. No, nothing else. Everything has been answered. So sincere thanks to you, and sincere thanks to Medgami team for always joining us. Dr. Anil Kumar, I see you in the panel. You can unmute and speak. Dr. Anil Kumar. I'm not too sure. It is by mistake it had happened probably. But anyway,
thank you, sir. Thank you so much. I was not able to unmute. It's a very nice meeting. I will just request you in personal chat. Thank you so much. Namaskar.
So thank you all. I think all good things have to come to an end. And the next program will be on coronary artery disease. And we'll be having a case of spontaneous coronary artery dissection presented, and we'll have the same format so that it will be interactive. Thank you so much. Thank you so much, one and all of you.
Thank you, sir. We enjoyed the session very nicely. Whatever also doubt we got cleared by this also. I think this should continue. We should learn from each other. Very nice.
One more important request to each and every one of you. I think you all shared a lot of points, all the panelists. Please write down in a Word file and share it to us. The questions that were asked to you and the answers that you had given. And to Israa and Professor Hasan also, whatever points that you have shared, you please share it to us, because we are going to bring out a Cardio-Obstetrics Masterclass 3 Q&A and chat box answers. This will be sent as a PDF file as a question and answers to everyone across the social media, so that people can get benefited from the Q&A sessions. So please do that and send it across. We'll continue to maintain this group for another 1 week so that we can finalize the masterclass group, masterclass Q&A session. So thank you so much, Professor Hasan and Dr. Israa. Thank you so much.
Thank you so much.
Thank you. Thank you, everyone.
Thank you. Good night.
Thank you so much. Goodbye. Have a good time.
Thank you,
everyone.
Thank you so much.
Thank you. Thank you, Professor Kajal. Very valid points. I think you're very strong. And in fact, you need to write up a lot because you discussed a lot. I wish you had brought in one of your assistants to type it out, whatever you are speaking. But anyway, I think now it is your job. You please type and send it across. It'd be very, very helpful to,
maybe we can
not
also
everybody
plan to
has the
write a
levels.
book
Not
later
every-
on,
Yeah, yeah.
case-based discussions. These are very good discussions. Maybe we can pen them down and we can,
Exactly,
because
exactly.
these are lifetime discussions. So many
Yeah.
questions in the
Yeah,
chat
right
box.
now I think we'll whatever this Q&A session itself can become a small booklet collection.
Yes, yes.
And so that is why we are focusing on developing this Q&A collection. So please send it across. So thank you
Sure.
so much. Thank you.
Thank you.
Thank you. Thank you. Thank you.
Thank you.